Hello, everyone. It's a great pleasure to talk to you regarding the newer aspects of type 2 diabetes management. Let's start with a patient, Mr. AB, who is a 48-year-old busy executive having diagnosed with type 2 diabetes 4 years back. He is hypertensive, having dyslipidemia and suffering from obstructive sleep apnea. Physical examination revealed his body mass index to be 32 kilogram per meter square, which indicates he is obese. His blood pressure is 130 by 82 millimeter of mercury. His laboratory measurements includes hemoglobin A1c of 8.3%. That reflects not a satisfactory glycemic control. Estimated GFR is 70 ml per minute. His low density cholesterol is 69 and triglyceride is a bit high, that is 250 milligram per dl. And also there is elevated liver enzymes in his laboratory measurement. Now his current medications include metformin 1000 milligram twice daily, lisinopril 40 milligram once daily, metoprolol extended release 100 milligram once daily, and atorvastatin 20 milligram once daily. Now, if we summarize this patient's profile, he is young, having a relatively shorter duration of type 2 diabetes with no apparent micro or macrovascular complications. He is at lower risk for hypoglycemia, so he would benefit from a more stringent glycemic target. However, he is also obese, hypertensive, having lipid abnormalities with obstructive sleep apnea. All these can increase the cardiovascular risk of this patient. Now, we know that American Diabetic Association recommend glycated hemoglobin less than 7% as a reasonable goal for most non-pregnant adults. In addition to efficacy, few other things should be taken into consideration while choosing anti-diabetic therapy for a patient like Mr. AB, like risk of hypoglycemia, weight loss or minimizing weight gain, baseline cardiovascular risk, renal function, and last but not least, the cost. Now, our patient, Mr. AB, is willing to start another medication, but he is concerned that he sometimes forgets to take his pills and fears that additional pills will make this scenario worse. He doesn't want to have an injectable therapy. So considering all these things, a fixed dose combinations here may improve adherence to the medication because there will be once daily dosing, less complex treatment regime, fewer pills, and an improved side effect profile and compliance. So as we know that people with type 2 diabetes can have multiple comorbidities, among which hypertension and cardiovascular disease are the most common. If we start with a single drug, this monotherapy actually cannot address these multiple defects. And what happens? It often leads to failure to maintain glycemic control over time. If we look at the contemporary guidelines, all guidelines encourage early adoption of oral combination therapies while simultaneously emphasizing the importance of individualized treatment as well. So if we look at the American Diabetic Association recommendation, it says inappropriate high-risk individuals with type 2 diabetes, the decision to treat with a SGLT2 inhibitor or a GLP-1 receptor agonist to reduce cardiovascular risk and prevent renal disease progression, that should be considered independently of the baseline A1c or with an individualized A1c target. In this context, a combination of SGLT2 inhibitors and DPP4 inhibitor, in particular empagliflozin linagliptin combination, should be discussed here. Now, SGLT2 inhibitors, as we know, is a class of novel oral glucose lowering agent that mediates glucose lowering by increasing the urinary glucose excretion via inhibition of SGLT2 co-transporter in the proximal tubule of the kidney. Now, this effect is independent of insulin secretion and action, thereby rendering it suitable to administer at any stage of the disease, may it be early diabetes or an advanced disease. On the other hand, DPP4 inhibitor exerts its glucose lowering efficacy by elevation of incretin hormones and subsequent augmentation of glucose dependent insulin secretion and inhibition of glucagon release. So combining these agents has potential to show the additive glycemic benefit due to their complementary effects. And from the evidence point of view, we know that empagliflozin in EMPA-REG outcome trial reported that the 3-point major adverse cardiovascular event outcome occurred in a significantly lower percentage in the empagliflozin group compared to placebo group on the top of standard of care. Additionally, cardiovascular safety of linagliptin, a DPP4 inhibitor, was further confirmed in Carmelina and Carolina trial. Now, if we look at the glycemic efficacy of this combination of empagliflozin linagliptin in the add-on to stable metformin therapy, it has been found that reductions in A1c at week 24 was significantly greater for both the empagliflozin linagliptin doses, that is 10/5 and 25/5 milligram, compared with the individual components. And furthermore, these benefits on glycemic control were maintained at week 52. That means a sustained effect on glucose lowering, which is present at week 52. Moreover, a higher percentage of patients achieved the A1c target of less than 7% for this combination therapy, that is single pill combination of empagliflozin and linagliptin. Now, this combination offers a suitable strategy to achieve target A1c without increasing the risk of hypoglycemia and weight gain, with improvement in overall lipid parameters. Another perspective is from the side effect profile. If we look, a reduction in the incidence of genital mycotic infection that is commonly reported with SGLT2 inhibitors also reported to be lower when a DPP4 inhibitor is added, perhaps because of a better glucose control and possibly other mechanisms that remain to be elucidated. So, if we summarize, empagliflozin linagliptin combination could provide a robust A1c reduction and 2 to 4 times higher odds of patients reaching the goal A1c compared to individual agents, and that can be achieved with a lower risk of hypoglycemia. So if we come back to our patient Mr. AB, at this point with A1c of 8.3%, and he is willing to take another medicine, but when compliance is an issue, so single pill combination of SGLT2 inhibitor and DPP4 inhibitor, in particular empagliflozin linagliptin, is a good option to initiate. And by initiating this combination, we can not only reduce the glycemic parameters, but also can help him to reduce body weight with lower risk of hypoglycemia, and also cardioprotective and renoprotective effects patient can have with this particular combination of SGLT2 inhibitors and DPP4 inhibitors, which has been shown to reduce cardiovascular risk, cardiovascular death, heart failure hospitalization, and also we have evidence that these drugs are good for kidneys as well. Thank you.